Introduction to Cardiomyopathy. Cardiomyopathy is a disease of the heart muscle that affects the heart's ability to pump blood effectively. The heart muscle may become enlarged, thickened, stiffened, weakened. As cardiac output decreases, organs and tissues receive less oxygen and nutrients. Cardiomyopathy can eventually lead to heart failure, dysrhythmias, sudden cardiac death. Categories of cardiomyopathy. There are 4 major categories of cardiomyopathy. Dilated cardiomyopathy, the ventricles enlarge and weaken, causing poor pumping ability. Hypertrophic cardiomyopathy, the heart muscle becomes abnormally thick, reducing blood flow out of the ventricle. Restrictive cardiomyopathy, the ventricles become stiff and cannot fill properly during diastole. Arrhythmogenic cardiomyopathy, heart muscle is replaced with fatty or fibrous tissue, increasing risk for lethal dysrhythmias. Pathophysiology of cardiomyopathy. Cardiomyopathy damages the myocardium and decreases cardiac efficiency. The weakened heart cannot pump blood effectively, causing decreased cardiac output, fluid overload, poor tissue perfusion. The body compensates by increasing heart rate retaining sodium and water, increasing workload on the heart. Over time, these compensatory mechanisms worsen the disease. Risk factors for cardiomyopathy. Common risk factors include viral infections, autoimmune disorders, malnutrition, alcohol abuse, genetic predisposition. Some cardiomyopathies are inherited. Alcohol and cardiotoxic substances may directly damage heart muscle cells. Impact on overall health. Cardiomyopathy affects physical, emotional, and social well-being. Clients may experience depression, anxiety, fatigue, loss of independence, decreased sexual libido, mood changes, financial burden. Clients may also experience adverse medication effects and difficulty completing activities of daily living. Most importantly, cardiomyopathy significantly increases the risk of sudden cardiac death. Clinical presentation of cardiomyopathy. Common symptoms include chest discomfort, fatigue, exertional dyspnea, palpitations, lightheadedness, near syncope, peripheral edema, ascites, JVD. As heart failure worsens, pulmonary congestion and fluid overload may develop. NCLX, clue, think heart failure manifestations plus dysrhythmia risk. Dilated cardiomyopathy. Dilated cardiomyopathy causes enlarged, weakened ventricles. The heart becomes stretched and cannot pump effectively. Common manifestations: fatigue, dyspnea, pulmonary edema, reduced ejection fraction. Common causes: alcohol abuse, viral infections. Genetic disorders: NCLEX clue, dilated equals weak, floppy heart. Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy causes thickening of the ventricular wall, especially the septum. This obstructs blood flow, leaving the heart. Symptoms may include syncope, chest pain, dyspnea, sudden cardiac death during exercise. This condition is often inherited. NCLEX, clue, young athlete sudden collapse. Think hypertrophic cardiomyopathy. Restrictive cardiomyopathy. Restrictive cardiomyopathy causes stiff ventricles that cannot relax or fill normally. This decreases ventricular filling and cardiac output. Symptoms: fatigue, exercise intolerance, edema, dyspnea. NCLEX clue, restrictive equals stiff ventricle. Arrhythmogenic cardiomyopathy. Arrhythmogenic cardiomyopathy occurs when heart muscle is replaced by fatty or fibrous tissue. This greatly increases dysrhythmia risk. Clients may develop palpitations, ventricular tachycardia, sudden cardiac death. Lab testing and diagnostic studies. Chest X-ray may show cardiomegaly and pulmonary congestion. CBC evaluates infection, anemia, and overall health status. Comprehensive metabolic panel assesses electrolytes, kidney function, and liver function. Troponin I and troponin T Evaluate cardiac muscle injury, BNP, elevated in heart failure and ventricular stretching. ECG detects dysrhythmias, conduction abnormalities, and chamber enlargement. Role of the nurses play a major role in monitoring, education, and emotional support. Assess activity tolerance, fatigue, dyspnea, edema, daily weight, pulse irregularities. If the client has an ICD, determine whether shocks occurred, how frequently shocks occurred. Safety considerations. Clients with cardiomyopathy are at risk for falls, dysrhythmias, sudden cardiac death. Monitor vital signs, oxygenation, dysrhythmias, worsening heart failure. Teach clients to report increased dyspnea, syncope, palpitations, swelling, rapid weight gain. Client education, teach clients medication compliance, daily weights, smoking cessation, alcohol avoidance, follow-up appointments, lifestyle modification. Encourage clients to avoid strenuous activity if ordered. Teach energy conservation techniques. Nursing process assessment. Recognize cues by assessing pulse irregularities, murmurs, JVD, edema, pulmonary congestion, ascites, fatigue, exercise intolerance. Assess ability to perform ADLs without worsening symptoms. Nursing process analysis. Analyze data for worsening heart failure, poor perfusion, dysrhythmias, fluid overload. Provide emotional support and reinforce treatment adherence. Nursing process priorities. The priority goals are improve cardiac output, improve quality of life, reduce symptoms, prevent sudden cardiac death. Nursing process, planning, collaborate with the healthcare team. Plan for medication management, dietary restrictions, fluid, management activity, modification, client, education. Nursing process, implementation interventions. Vary depending on the type of cardiomyopathy. Implement medication administration, lifestyle, modification, oxygen therapy, if needed, monitoring for dysrhythmias, surgical intervention, preparation, nursing process, evaluation. Evaluate whether the client has improved activity tolerance, has decreased edema, has improved oxygenation reports, less fatigue, maintained stable cardiac rhythm. Outcomes may be improved, worsened, unchanged. Non-pharmacologic treatments. Lifestyle changes are essential. Teach dietary modification, weight loss, smoking cessation, avoid alcohol, avoid illicit drugs, avoid strenuous activity. Energy conservation is important. Pharmacologic treatments. Diuretics reduce fluid overload and edema. Example, furosemide. Vasodilators reduce cardiac workload. ACE inhibitors decrease afterload and improve cardiac output. Beta blockers reduce heart rate and myocardial oxygen demand. Angiotensin receptor blockers used if ACE inhibitors are not tolerated. Mineralocorticoid antagonists reduce fluid retention. Calcium channel blockers may improve symptoms in some forms of cardiomyopathy. Surgical interventions. Heart transplant used for severe end-stage cardiomyopathy. LVAD, left ventricular assist device, helps pump blood from the left ventricle. Septal myectomy removes thickened septal tissue in hypertrophic cardiomyopathy. Alcohol septal ablation creates controlled destruction of septal tissue to reduce obstruction. ICD, implantable cardioverter defibrillator, prevents sudden cardiac death from lethal dysrhythmias. High-yield NCLEX review, dilated cardiomyopathy, weak enlarged ventricle, hypertrophic cardiomyopathy, thickened ventricle, sudden death risk in young athletes, restrictive cardiomyopathy, stiff ventricle, poor filling, arrhythmogenic cardiomyopathy, fatty tissue, replacement dysrhythmia risk. BNP, elevated with ventricular stretching and heart failure. ICD, prevents sudden cardiac death. LVAD, assists weakened left ventricle. Daily weights, best indicator of fluid retention. End of lecture activity, have students identify type of cardiomyopathy, hallmark symptoms, priority nursing interventions, medication therapy, safety concerns, signs of worsening heart failure, example, young athlete with syncope chest pain, and sudden collapse during exercise. Correct answer, hypertrophic cardiomyopathy.